All right.
How are you? Yeah, good. How are you? You're good. We're just saying that.
Okay. All right. Thanks everyone for coming again. Another week of fantastic talks for the seminar series this semester. Before we get started, I first want to acknowledge that we're meeting on the lands of the Ngunnawal Ngambri people here on ANU campus. I just want to acknowledge and pay my respects to the traditional custodians of the lands in which all of us are meeting and coming from today, and also welcome and pay my respects to any Aboriginal Torres Strait Islander peoples in the room and online. Okay, so I've got a few quick announcements before we jump into interesting research. Firstly, a huge congratulations to Samantha Stanley and also to John Yanna, who recently found out that they awarded a DECRA, which is very exciting. So yeah, we had that all planned out, which is why John's here today. No,
really?
Just kidding. Yeah, really fantastic achievement. So big congratulations to Samantha and John. And I also just want to remind everyone that we will have a break for the seminar during the teaching break, so there won't be a seminar for the next couple of weeks, and we'll be back on board on the 21st of September. And I think that was it. So without further ado, I'm going to introduce our first speaker, Associate Professor Anna Olsen. Anna is an Associate Professor of Social Foundations of Medicine at SMP. Her interdisciplinary program of research combines practical and critical approaches to public health with a particular interest in marginalized populations and qualitative methodologies. Current research includes pill testing, opioid overdose prevention, methamphetamine use, drug use and motherhood, domestic and family violence, Aboriginal and Torres Strait Islander health, and ethical practice in social research. She values collaborative approaches to research and has extensive experience working with government and community on evaluation and research projects. And today Anna's going to be sharing with us some of her work she's been doing on Australia's first drug checking service. Thanks, Anna.
Thanks, Jo, and thank you to all the lovely site colleagues who are here today, and hi everyone online. So a few acknowledgements before I get started. First, I'd like to acknowledge my co-authors here on the slide, who are across UNSW as well as UTAS, who are the team that developed up this work and ran this work with me. I'd also like to acknowledge the Ngunnawal and Ngambri people on which the CanTest service sits, and I'll be introducing the CanTest service today, and thank you to the traditional custodians of this land. My final acknowledgement is that today, which part of the reason I wanted to present today is actually International Overdose Day. It's a big day in my sector. I work in drug and alcohol. There are events all around the world today, and lots of people pausing and thinking about people who have been lost to the war on drugs. In Australia, there are 5 drug-induced deaths per day, and this comprises 1% of all registered deaths in Australia. And an unregulated drug supply is part of what's contributing to this rate of drug overdoses in Australia. So what I'm going to do today is I'm going to introduce you to this novel health service in Canberra, literally down the road. It's sort of 5-10 minutes away, just on the edge of campus here in the city, on One More Street. Give you a brief summary of the evaluation approaches that we use to evaluate this service and a brief summary of the findings. I'm going to whiz through it pretty quickly, given the time. So as I mentioned an unregulated drug market, and by that I'm talking about illicit drugs, and the markets in which illicit drugs move are in no way regulated, meaning that the type and quality of substances available vary widely. And this variability in illicit drug composition, so the dose and the presence of particular substances and particularly adulterants, can elevate risk of harm, including overdose. Without objective information on drug contents, people have limited capacity to understand potential risks of use and modify behaviour accordingly. What I'm talking about today is linked to health intervention which aims to reduce the risks of drug use, and this is called a drug checking service, also known as pill checking services. About 5 years ago in Australia, we called them pill testing services, and now we've transitioned to drug checking because they analyse all types of drugs, not just pills. These services, which have been available around the world for decades, actually aren't new. They feel really new and scary for Australia, but actually they've been throughout Europe for decades and are increasingly growing across North America, where we have an opioid epidemic. So what these drug checking services do is tend to undertake chemical analyses of drugs that people bring in. They can provide qualitative information on the presence or absence of a substance, and sometimes also quantitative information about the amount of substance in what's being brought in. So they're established with the aim of reducing harms and returning findings of these chemical analyses to the service user and or the general public. Often drug checking services provide tailored interventions around reducing harms from drugs alongside this, and contribute information to organisations that monitor drug trends. There's a range of types of models that provide different levels of access to the public, including mobile and event-based services, mail-in services you can see in some parts of the world, and what we have here in Canberra is a fixed site bricks and mortar service. Despite the fact that drug checking has been around for a while and there's quite a few of them, the evidence base for drug checking is still developing, and there's not very many independent evaluations of services that have been published. So the team and I are quite proud of our work and really pleased to contribute to the international information that's been developing around the actual impact of drug checking services. So just a quick rundown of what's happening in the ACT. The ACT is the only jurisdiction in Australia, go ACT, that's approved drug checking services. We had a couple of trials at the Groove in the Moo Festival in 2018 and 2019, and they were run by Pill Testing Australia. And the team and I independently evaluated the second trial at the Pill Testing Festival. Pill testing tent at the Groove in the Moo Festival, and building on these promising results, it was also a great example of where research can have a really big impact in policy. The evidence that we developed from that was used by the government to support the establishment of a 6-month pilot of CanTest, this fixed site health and drug checking service, from July 2022 to January 2023, and it's this 6-month period that our evaluation covers. The service is run by a consortium of organisations, including Directions Health Services, in conjunction with Pill Testing Australia and Canberra Alliance for Harm Minimisation and Advocacy, and CARMA, that last group, are our wonderful peer user group in Canberra. Given the need for evidence of the feasibility and effectiveness and the outcomes of this service, so we were requested to run another evaluation, and that's what I'll be detailing pretty quickly through today. So what happens when you go into CanTest? Because it was a pilot service and it was run for 6 months, and it's been extended and it's been extended again. It's now got funding until the end of next year. The times, however, have stayed pretty much the same throughout this pilot period. That's 2 days a week in the afternoon, evening. On site, there's chemical analysts, a drug and alcohol counsellor, a peer educator, a registered nurse, an on-call medical officer. So what happens is you come in, you are screened to make sure that you're competent and that you agree to the rules of the service. You sign a waiver to say that you accept the information that's given, which includes that drugs cause harm, and this information we're giving you doesn't mean that these drugs are safe to take. Put a phone in a locker. most people do a pre-test survey if they agree to it, do a pre-test survey, and then they go in with the chemists and have their substance or substances tested. You can take up to 5 different substances. Then with those results in hand, they'll have an intervention with a nurse and or peer educator, and then most of them end up doing a post-test survey on the way out, and any other general health interventions are provided on site as well. In terms of the kind of chemical and analytical part of it, even though I've been doing this work for 5 years now, I still can't sort of get my head around the fancy machinery. But in short, there's a machine that all drugs go through, which is FTIR, and that gives a qualitative result, which tells you the presence or absence of drugs. Most people also agree, well, a lot of people also agree to have a fentanyl test strip, and fentanyl is a drug that's sort of ripping through America at the moment, or North America as well, Canada, is a very potent opioid, so we'll often do a fentanyl test strip as well. And then many people also agree to do the testing, which takes longer because it is fancier, and that's UPLC testing, and that's where you can actually give a quantitative result around quantity of drugs too. So not just what's in it, but what kind of quantity. And then as you can see there, the service is also a health service. There's a whole lot of different interventions that can be provided because there are nurses on site. So in terms of our core evaluation questions, this is, keeping in mind that this is evaluation is sort of adjacent to research. It's not exactly the same as the type of research questions we ask. They're slightly different questions because they're more about impact and effectiveness and acceptability. So we asked, was the service implemented as intended? Who was accessing it? Was the service needed and accepted by people who came in? Did the service have any impact on people who came in? What kind of information about drug availability and harms was produced by the service? Any unintended consequences, which is a really common evaluation question, and also the financial costs of the service and recommendations for service delivery. We had lots of different data sources, which is also really common in evaluation. So we had the data that the service produced, we had the chemical analytical data, we had pre-post surveys. Something that's really unique to our evaluation is we did follow-up. So part of what we don't know in this field is behavioural change. We actually don't know very much about behavioural change because there hasn't been much research in this space. We often have information from people in the service and they'll tell us their intentions, but we very rarely have information about what they actually did when they left the service. So I'm really proud of the team for building this novel approach to collecting follow-up data. So people who agree are sent an email or a text and conduct an online survey. So we've got the biggest data set in the world around follow-up data from drug checking services, which is really exciting. And then of course, because I'm a qualitative methodologist, I also have qualitative data, and I called up people who let me and had a chat to them about what they did after the service and what they thought of the service. And I also interviewed key stakeholders. So I'm going to quickly whiz through our key findings. I'm going to go through them pretty quickly so that we can have some time for questions. To what extent was the service implemented as intended? We found that it was implemented absolutely as intended. It did have to be tweaked for, to accommodate particular limitations of the building it was in and to accommodate the different needs of the different staff members there, but it was absolutely implemented as intended, which was to provide a drug checking and health service to people of Canberra. In that first 6-month period, so this is for the first 6 months only, not later, almost 500 people came in, and most of those people visited for drug checking. Sometimes they were there for other reasons, and most people ended up receiving drug checking, had their drugs checked. Who was coming in? Most people are from the ACT, but we know people are travelling borders to get to CanTest because there is no other service in Australia. So, people are coming from Melbourne, Queensland, also when there's festivals in town, obviously lots of people come from interstate from that, but most people are from the ACT region. Most the most common person coming in is a youngish male. Most people had never tested their drugs before. And one of the most important findings that we have, something that's really is really valuable to know in terms of evaluative information as well as health intervention assessment, is that the majority, 70%, had never previously accessed a healthcare worker before. So this is, for most people coming in, it's the first time they'd ever talked to someone about a professional about their drug use. Now, it's not to say that people coming in necessarily needed to talk to a health professional about their drug use, because a lot of people were sort of, fairly casual users. But the fact that it's the first time they're coming into contact with a professional and talking about their drug use and getting quality information is a massive statement of impact of what these kind of services can do. We had quite a few frequent flyers, so around 60 of them returned for more than one visit. Fridays were the most popular, which is important to know for service provision, and after hours were most popular. The service is continuing at the same hours at the moment, but certainly one of our recommendations was to consider extending opening hours. Most people visited by themselves, which is quite different to what you see in festivals where you're more likely to see groups of people come in. Most people, which is also really important when you think about this as a health intervention, did accept some sort of health intervention. So whether that's chatting to a peer about their drug use or seeing a nurse about something. And this service, in that first 6 months, issued over 1,000 health interventions. So it's not just a drug checking service, it's also doing, contributing a lot to the to health in the ACT. The service also facilitating access to naloxone, and important to mention on International Overdose Day, naloxone is the substance that can reduce opioid overdose. So facilitating access to that's really important. What did people want and what was accepted? You don't often see this in health services, but close to 100% of people rated the service 10 out of 10, felt respected and felt the communication was excellent, that they'd recommend the service to others. Like, you don't see these kind of ratings very often. And we also had some great qualitative data about that. I wanted to come in because I wanted to basically protect my friends. I didn't want to provide stuff to my friends that was potentially dangerous. Or I think it's a really good way for the community to stay healthy. And it's interesting. I'm just wanting to come and check the service out. So really a lot of positive feedback from service users as well. In an evaluation sense, we're interested in whether the service provided valuable and timely information about illicit drug availability and harms in Canberra. And this is something that we're quite interested in. An unregulated drug market is not only providing information back to the person who turns up, but public notices. So if there's a particularly dangerous drug in the market, it's providing that information to people. And again, one of the most important findings that we had from the evaluation, which reflects the drug market that we have in Australia and all over the world, half of the drugs that were bought in were not what the user expected.
Hi.
Huge, right? Half.
Sorry to bother you. Can you hear her voice? No, Anna Olsen's.
No.
You're sitting on the seminar?
That's okay. Do you want to do that, Joe?
Yeah, so you can't hear.
Yeah, but I can't get any voice. I can see the video, I can see the screen,
I can
but
hear
I
it
can't
very
get
clearly.
a sound.
It's Carolyn Hawkinson. I can hear it very clearly online.
Okay.
Me too.
Could be an issue on.
I'm getting it through you, but not at my end.
Oh. Okay.
So you've got her voice, it's on. I think I'm going to go insane here.
Yes.
That's okay. Never mind. Go back to what you're doing. I just wanted to
All
check
good.
if.
Sorry, thanks for bringing
Okay.
it to my attention.
Thank you.
Okay, thanks, Rosalie. Hopefully you can figure that out. Okay. So so that was one of our most important findings. So we know that it's an unregulated market, and we know that products that people buy are don't necessarily contain what they think they're buying, and this shows that that's absolutely the case. Over half the test results detected something else that the user wasn't expecting. Now, is that necessarily always something harmful? No, sometimes it's really sort of innate, benign substances, like sort of toothpaste, but sometimes they're very dangerous substances. And the service has absolutely produced valuable and timely information, and when particularly dangerous substances have been found in samples, the service issues community warnings as well as dangerous drug warnings from the ACT. So there's been a number of those that have come out, and the service has also in fact discovered new substances that haven't been recorded elsewhere as well. There's a growing market for what's often called research drugs, and that's something that's growing in a big way in Australia, and people often think that they're buying benzos, but there's or ketamine, but it's often a slightly different version of that drug, and we actually don't know what these drugs do. Okay. So to what extent did the service result in users' attitudinal behavioural change? So as I mentioned, this is something we're really interested in because we just don't know much about this across the globe, despite the fact that we've had lots of drug checking services. And our results didn't show anything particularly unexpected, and it echoes what we found in, for example, festival research. But what we have is, because we've got follow-up data, and these are from the follow-up data, we know that there is, people are often, we know what people are actually doing with the drugs when they leave the service. So we know that if the person is told that the drug contains what they expect, they're more likely to use it. If the person's told that the drug contains something that they didn't expect, they're less likely to use it. An important question for us in terms of health and harm reduction was, there is people who are opponents to drug checking services fear that drug checking services provide a green light for people and attract people and in fact encourage people to take drugs, but we're finding that most people are saying that they're not trying to go out and obtain more of the drug that they had tested. So it's sort of not necessarily creating that honeypot effect that a lot of opponents are worried about. So I'll whiz through that really quickly. I'm looking forward to questions, but just to wrap up, we, the evaluation team and I, concluded that CanTest, the drug checking and health service, is providing a highly valued health service in the ACT, and we supported its continuation. And as I mentioned, the government has continued funding until the end of next year. We found a number of considerations. There were a lot of unexpected costs with the service, so a lot of costs that weren't necessarily anticipated by the team, and funding is an ongoing issue. Reaching out to and attracting people who inject drugs is an issue globally for drug checking services, and we're certainly finding that in Canberra too. There's quite a small proportion of people who inject drugs who are coming into the service. When there's a festival in town, the service cannot provide enough drug checking, like there's more people than we can provide services for, so that consideration, although the service does consider that surge capacity at the moment is limited, so thinking about expanding that. Thinking about expanding approaches to testing as well. So the fancy equipment they have still can't test everything. So some samples are being taken to ANU, in fact, because the chemists are here at ANU for further testing. So thinking about expanding those testing approaches, and also the use of media and social media to attract people in. So if anyone's interested in the evaluation, I put the link up there, and the CanTest site is linked to the Directions Health site, and just a reminder to spare a thought today of people who've died as a result of the war on drugs. Thank you very much.
Thanks so much, Anna. Any questions? Sorry, we'll go Alicia first, and then
Do I need the mini mic?
we don't have a mic.
I'll repeat the question, Alicia.
I was just wondering, and the people that you rang up to interview later, do you think that this testing facility has had any impact on the drug supply in Canberra, like improved or, you know, hold dealers more accountable if you say, hey buddy,
Yeah.
take this, but
Such a good question. So a question from Alicia is basically whether we have any data to suggest that the drug checking service has had an impact on the drug market. So we definitely have some anecdotal evidence to suggest that sometimes people have gone back to their dealer and said, you know, hey, did you know? And that has been communicated back. So we do have some anecdotal evidence about that. Because the service is so small in a small jurisdiction, it's only just started. We can't do any sort of population longitudinal work yet, but in Europe they have. And there is some quite strong evidence to suggest that the presence of a drug checking service over time has an impact on the drug market, and drug checking services find less adulterated substances. So great question.
And another follow-up question, sorry. I know that a lot of drugs are being decriminalised very soon in ACT. Do you think CanTest will get more funding now that people might be more open about getting their drugs tested now that they are not worried they'll be, you know, charged for just having it on the person?
Yeah, thanks, Alicia. Another great question. So the question was around the decriminalisation laws which are coming into the ACT in October, so very soon, where the most regularly used drugs are being decriminalised here for possession, not for trafficking, but for possession, and what kind of interaction CanTest service and that might have. And you know, it'll be really interesting to know. Certainly a couple of people who I talked to in the follow-up interviews said, well, I know that ACT is decriminalising drugs and that makes me feel safer. And so I came into the service because I feel like I'm not going to get caught by the police. So it seems, again, kind of anecdotally that, you know, that is having an impact on people feeling safe, because obviously we did also ask people if they had concerns about coming in, and certainly some of them did, because it's in a health building and they've got, you know, they have to carry drugs to come in. So, you know, there were concerns about that. But there is an agreement with the police force and a safety zone around the building. And it is very, very safe, but to get that information out to people is difficult. Yeah.
Yeah, thanks, Anna. I should talk about your research for our science communication and social change course this Monday. So,
yeah.
So I just want to get a follow-up question regarding with ACT policing. Are there differences, for instance, in the agreements with the police for like the Groovin in the Mood festival as opposed to the one for this kind of like, you know, like testing on site, especially for people, you know, who actually, for instance, they have to go to the building, you know, but they're not protected when they're transported?
Yeah, good question. So John's question was around agreements with police and how they differ across different services. It's not something that I know about intimately, but I know that in both occasions there is an exclusion zone around both the fixed site service in the city as well as the pill testing tent that was at Groove in the Moo. So the way it's generally been negotiated in the ACT is an exclusion zone. Oh. So policing can operate in other areas, but there's an agreement that the police don't come into the vicinity and don't watch the vicinity either. So yeah, the policing in the ACT is quite different to other states and territories, and it has been easier to negotiate drug checking services here than it has been in other areas.
Maybe one more question, Bruce.
Thanks. First of all, congratulations. Great service and great outcomes. The question I have is, you know, another cornerstone of harm reduction is safe injection sites. So my question is, are those available in the ACT? And depending on the answer to that, would it help to co-locate those in order to increase the check-in that would happen with the injectable drugs?
Yeah, such a good question. So Bruce's question was around safer injecting sites and, you know, what we have in Australia and whether we have in the ACT and how we might think about the possibility of co-locating drug checking and safer injecting sites. So at the moment in Australia, we only really have kind of like two major safer injecting sites, which you see in the news all the time. They've stayed in pilot phase for like a decade. It's still highly controversial. And there is discussion and political will in the ACT to have either a safer injecting room or a drug consumption room, which is a slightly softer version of it. I have some pretty strong views about what's happening in harm reduction in Australia, and I think we're a bit stuck in harm reduction in Australia at the moment because we have a very medicalised approach to harm reduction. We'll do these things, but only if there's a doctor. But actually, if you look to places like Canada, a lot of these sites are run by peers. So yeah, there might be like medical professionals providing information into it, but they're run by trained peers. They're low cost, they're hugely effective, and I think Australia's missing out by over-medicalising all our approaches to harm reduction. If we can utilise our peer workforce more, we have a strong peer workforce here, we will do much better in harm reduction. So thanks. That wasn't a Dorothy Dixer, it's just a great question. Great. Thanks so much.
Sorry. Start the next. Okay.
I need to stay in this vicinity, right? So that I could be heard.
So I'll show you what the.
Oh, okay, sorry.
So you can move quite a bit. Yeah.
Okay.
All right, so our second speaker is Dr. Jean-Noel Viana, and one of our ANU's DECRA recipients, so we're super excited to have him here. John is a research fellow at the Australian National Centre for Public Awareness of Science at the ANU, and also visiting scientist at the Responsible Innovation Future Science platform of CSIRO. Initially trained as a molecular biologist and neuroscientist, he shifted his research to bioethics for his PhD and to science communication and social studies of science for his postdoc. He's currently exploring equity and diversity issues in precision health research, from systems biology for COVID-19 prognostication, I said that right, to digital health status monitoring for end-of-life care. He has also recently published book chapters on queering science communication and on science communication with racial minorities during pandemics. And his presentation today is titled Racial Diversity in Biomedical and Health Research, Challenging Conversations and Situational Solutions. Please welcome John.
Yeah, thank you so much, Joe, for the invitation to actually present at this conference. So Joe and I work on an MRF application, which we hope to launch again soon, on intersectionality. And then, so I'm just from downstairs at CPAS. And so my research actually really revolves around racial diversity in biomedical and health research. And I think it really is more of a conversation for this presentation, just to show what my work is and what research are we doing, and perhaps even to, if people at SMP would be interested in collaborating, especially with the DECRA, then I hope to use this opportunity to just, share what I'm planning to do as well, and to perhaps establish connections, but also explore potential ways in which we could all work together. So, so I also would like to acknowledge that we are currently in the unceded lands of the Ngunnawal and Ngambri peoples, and I pay my deepest respect to their elders past and present. So my research actually, at least went through the ANU-CSIRO contract, is responsible innovation in precision health, which is, just really foreshadowing what the future of health is like. Before we just, health is just thought of something that's medicalized, or, it's like you get sick, you go to a doctor. But with a vision of precision health, we're actually, well, at least the vision is actually to have health monitoring throughout the lifespan, starting with risk assessment at all life stages, having integrated health portals, but also customized monitoring through all sorts of devices. And of course, it aims to integrate various data sources, such as phenotype, lifestyle, environmental factors, but also with more medical or, biomolecular factors and genetic factors to actually monitor health, but also prevent disease and address disease when you actually have a condition. So of course, it is something that Sarah has invested in with their Precision Health Future Science platform, and they had this wonderful vision of how a precision health system could actually work, where there's a lot of like health screening and testing all throughout the lifetime, which of course raises as well not just sort of benefit, but also all sorts of privacy issues and medicalization of everyday living. And so because of this, and of course that was just a vision. This is the reality, and this is something that's just starting to really be used, because of course you could probably imagine how expensive something like this would actually cost. Of a study in Stanford that utilizes a lot of personal, clinical, behavioral imaging, and all sorts of data you could potentially imagine to monitor people with cardiovascular disease for 3 years. And it's like they said that even if you just report to people that they have this predisposition to their lifestyle, then it could lead to some behavioral changes. So then anyway, so what the things that actually started all these work on equity and diversity in health research was when we did a scoping review using different keywords to actually understand how is precision health and its synonyms on personalized health, tailored health, stratified health, and integrated health actually understood and actually practice. What sorts of data they actually use, what kinds of interventions are we talking about? Is it more of monitoring? What sorts of devices or tools are they developing? And I will not go through the whole research because it's not really the goal of this presentation. It's more to just foreground the work that we do. But it's like we had 225 studies, and what's really alarming is that understanding the trends and gaps, a lot of these is pretty obvious. Most people are around 48 years, and of course with challenges in getting ethical approvals, but also with procedures in place, I guess, for the drug testing. You're gonna get people less than 18 for these things. So it's like, well, a lot of there's also like age disparities, wherein out of the 225 studies, there are not that many who recruit younger and older populations. But of course, what is really interesting is that it's like not all the articles actually mention the participant's sex or gender, which is something that is quite common, in like I guess psychology or public health. But of course, a lot of these papers, some of them are written by computer scientists. So because as you can see, like research on health and medicine is not just undertaken in medical or public health departments. Now, with these interests in precision health, there really is actually increasing interest from all sorts of domains, and only less than 40% of the articles actually mention participant race or ethnicity, and I guess less than 20% of the articles actually included people from low socioeconomic backgrounds. And the focus of this talk would be to reflect on, of course, the concept of inclusion of participant race and ethnicity, and hopefully this would be as well my DECRA, but hopefully eventual research we could look more into intersectionality, which understood how our sexual or gender minorities, people from disadvantaged backgrounds as well intersect with their race or ethnicity, and to what extent are these actually understood in health research. But I think this is really challenging, because if we cannot even get people to report participants' race or ethnicity, or collect the data or their sex or gender, which is quite common now, then of course it's more challenging to even step into the domain of intersectionality. So of course I guess as most of you know, more than I do probably, that there is underrepresentation of people in clinical trials, and a lot of FDA-approved drugs have been usually tested on Caucasian populations, and not that many have actually been tested in various indigenous populations, from Native American to people who are Hispanic, which of course is quite interesting because Latino or not is only a US construct. Like that's an ethnicity is a North American construct, which is usually not collected in other jurisdictions. But of course, there's a lot of less representation as well of people from African American backgrounds. And I think when we look at the global scene as well, not just from North America, it's even worse. And it's the same thing with, anti-cancer drugs, in which even though the incidence and mortality of these drugs are actually way higher for, Hispanic and Black populations, their enrollment in clinical trials is sadly less. And of course, we could foreground these in a lot of calls, every field from neuroscience to cancer to, prenatal health, to epidemiology, or to broader medical journals. That is called, yes, in light of the Black Lives Matter movement, in light of the Asian hate during COVID, of having greater inclusion in research. But then, everyone can write a 500-page paper, but what needs to happen? Is it the same for every condition? Should it be the same for every context? Not just in a country, but across different states, considering differences in demographics, across different regions. So I think this is really what my research tries to understand broadly, is that, yes, it's good to have calls, and it's good to have calls both from the social sciences, from the medical sciences, from public health. But then the next question is, how do we situate these calls? How do we make it happen? And who should actually make it happen? So, so the question is, how do we fill this gap? And it is important to understand the gap because it is challenging. Because, for instance, there's this tension, for instance, of collecting data and protecting people's privacy, but also as, how do we conceptualize ancestry, race, ethnicity, and to which context do they even matter? Or when we collect our sex or gender, how do we let people identify? And how do these different factors actually matter in different kinds of contexts? Do they matter in psychological interventions? Do they matter more in genetic tests? But also situate which exact gap are we feeling? How does context actually influence that diversity? So I'll just use it's just 2 case studies, and the third would just be to just briefly talk about my DECRA, and which hopefully to perhaps invite people who might be interested in joining this effort to work. So I'll just present 2 conceptual projects. One is on multi-omics or inheritance systems biology for palliative care, and this is just more of a theoretical work. And the second is 18-month participant observation and interviews in a COVID-19 systems biology project, which I will describe actually later. So now, with advances, as I mentioned, in biology, people are trying to not just do, the genomic age, I wouldn't say it's over, but, it's like genomics is 2000s. And now people are trying to actually, draw from all these sorts of different omics, from your proteomics, lipidomics, transcriptomics, phenomics, and every omics you could even imagine. And of course, try to integrate, not just, predict your health status from just one omic, but try to, of course, leveraging all the advances in AI and machine learning, try to integrate a lot of this information to better predict, how long people have to live, for instance, with cancer, which of course have implications for palliative care. And, in some instances, they've used microRNA data from different samples, using some fancy mathematical modeling that I probably could not understand, to actually predict and stratify people into their survival rates. So, it's not something that's science fiction. It's something that's actually happening, and people predict people's survival rate, and they are grouped into 3 different groups, high, medium, low, which, this paper is currently in press already, but it's more of ethical and social issues. So I won't talk about the ethical, because I'm also an ethicist, so I wouldn't talk about the ethical issues associated with this, but I would just like to focus on equity issues. So of course, as we can see, and as is reflected in so many different domains, for this prognostication, a lot of, native or indigenous populations or Hawaiian or, minority populations are also underrepresented. And of course, people could question race, but of course, it's ancestry is something that perhaps influences people's biology, which of course is very obvious, for instance, in the alcohol dehydrogenase gene, right, which is more prevalent in certain Asian populations than in Caucasian populations. And it's perhaps related to biology. And of course, even for all the studies, not just in cancer, but also kidney failure, most of the studies, as also we've seen in our scoping review, did not even report participant ethnicity and ancestry. And with the interest of time, I'll just probably skip this slide. It's just more of, how different cultures communicate end of life. So, you have these magic numbers that you can give to people. Of course, it's still debated whether or not physicians would actually use them or communicate them. But then where do you go from here? And how do we actually think about not just representation in terms of who gets the blood and who gets represented in these tests, but also how do we make sense of these tests? And whether or not we acknowledge if people even need these tests when you only have a month or 10 days to live. The next would be, I guess, a bit more interesting because it's our own data. It's still an ongoing, well, I've already finished the interviews, but it's something that we're currently coding thematically. And this just involve, as I mentioned, the goal is to determine all this fancy omics stuff and, to see how it changes 6 months post-COVID infection and 12 months post-COVID infection, to see how it relates with people's prognosis. So of course, there are cases and controls. It was done in Geelong because, well, that's where our collaborators are, and with 2 groups or organizations. And what I conducted, because it's during COVID, was just to participate in all the team meetings. And when restrictions were a bit lessened. I was able to visit the sites where they conducted the tests and have semi-formal conversations with researchers. So it's a much bigger group than just two, but the one that I've actually interacted with was the clinical trials team and the team doing this fancy omics stuff. And this is a biosafety level 4 place. And so I've done 6 semi-structured interviews. I'm members of the research team, but it's not just, like I just come blindly because, these people I've been working with for 18 months. So the interviews actually had a lot of context, especially for the follow-up questions. So it's like a semi-ethnography approach. And we can see, of course, what are I'll just quickly go through these. So, present some of the factors which actually could influence participant diversity in a study, which might not, which could challenge these broad brush calls on diversity. So if you're in a place like Geelong and your partner organization can only recruit from that Barwon region of Geelong, then of course, if it's not as diverse, you wouldn't expect the same level of diversity as you would if you're in Sydney or in your Western Sydney or Western Melbourne, which of course, when people are trying to propose these diversity quotas, then these pragmatic realizations of research should also be taken into account because of course the demographics is different. And one of the researchers said that of course, yeah, Geelong they might just be hanging out in the wrong place. It's not a very large diverse area. And of course the census data, at least according to birthplace, also reflects this information. The other thing is research objectives, which brings into question, how do we make sense of participant ethnicity or race or ancestry? Do we incorporate that in the research question itself, or is it just something good to report on? And I think it really is a valid point because they said that, for instance, one of the researchers said, well, this is not the objective of the project. We're not comparing different groups. And of course, this would have implications for statistics because, if you want to have that kind of objective, then you need to cover maybe not all, but at least for this research, you need to cover for all the genetics because it's doing your RNA levels from Chinese to Korean to Japanese, and for Indian, and of course, do we use the census classifications? And the American census classification is different from the Australian one, from the Canadian one. And so how do we make sense of these groupings, especially if it relates to someone's biology? And of course, these are statistical issues such as stratification. How many numbers do we need to even have statistical validity? And so, these questions of diversity are actually more complex than just having warm bodies in there or just reports. And hopefully this study would really unpack, it's like, well, it's not as, it's a nice thing to have. And I'm not saying that we should not have diversity, but I think it is important to situate these calls in realities of research, but also in realities of statistics of how people make sense of the science. And of course, the recruitment strategy. So obviously, this is a COVID-19 study. So whoever gets COVID will be the one recruited. And even though some people propose it, it's still a bit, well, not a bit, but it's quite unethical to just infect people with COVID for the sake of diversity. So which of course, brings into question, well, I guess for infectious disease research, it's kind of a different kind of consideration, as opposed to with mental health or, with alcohol and drug use or with dementia. So of course, so the goal of how they recruited was that, of course, because it's in partnership with the health agency, they get a list of people who had COVID and their phone number, and so they actually have to call them, and these are people who are from English-speaking backgrounds, so they don't speak minority language or other languages, and people could also text them, and of course and if someone who doesn't speak English, they have someone else at home who speaks English, then family members actually play a role. But of course, I didn't present it, but somebody they said, if we cannot understand each other, we just give up. Which of course, I mean, it's not good, but in a way it makes sense because, if you are under time pressure as a researcher, you have targets to meet, funding is only for 1 year, all your collaborators are kind of pressuring you to recruit an X number of people. You only have 6 months before, the results would be influenced because it's a different variant already, or there are vaccines already. So this is another part of the project, which is just, to see how well, the pandemic itself shapes what kind of pandemic science we have. And so going back to diversity, well, I guess, these are all issues, but also this is the other issue I think that also relates perhaps to alcohol and drug use. Some people would just be less likely to go and seek help because, if you are a migrant and you don't have job keeper or job seeker and you have a casual job, you have to pay for your bills, then, actually going and it doesn't for COVID would mean that for 14 days, your family won't have anything to eat. And so, and of course, the case would be what they plan to do is that, of course, there are cases and they would match it with the controls from the Australian electoral roll, which I think is quite obvious that, of course, if you cannot vote, then you will not be represented. Which is, really highlights, even these recruitment strategies actually have an influence on who gets to be in a study or not. And of course, if you have a social media campaign or if you have an electoral roll, then these would have different repercussions for participant diversity. Of course, when through the electoral roll, you have to send a letter to each person, but then you cannot predict, which letter you would want to send, and everything mostly will be English, which also relates to still, linguistic issues, because you cannot send a whole book of like 50 different language letters. People want, short letters, and one of the respondents say, it's like, I don't even read junk mail. If, if we see an invitation on the mailbox, usually we just throw it away. And how would you expect people who might not be so used to having, to a clinical research culture, even respond to them? And this is how, I guess your recruitment really has a profound impact actually on diversity issues. And, people have said that, well, it's good if, if we have diverse research teams, then perhaps we could have diverse participants, but it's way more complicated than this, because if your research team who is diverse, even if you have 30 people from minority backgrounds, but they are the ones pipetting, they're the ones doing the lab work. So they don't even have any say on the recruitment. But also when they enter the research, so if you came from the research a bit late and your organization is just piggybacking on something that's already running and ongoing, it's like something that perhaps aimed to just look at people who had COVID, ask for psychological studies on how are you feeling, or just medical studies on how's your lung function, and then you just hop on the project wanting to do all this fancy omics. Well, obviously, there's you don't really have much say if people already finished the protocols by the time you entered. And as well, it's like one of the participants says that, well, most of the recruitment team are Caucasians, and in Geelong, they don't even collect ethnicity data. So we don't even know how to represent or whether we're hitting the diversity targets in health research. So this is just to say some of the complications in research, and hopefully my DECRA will move from, well, hopefully once we finish this infectious disease, it would be a nice way to compare it with mental health. And perhaps, if there are colleagues in medicine or psychology who are interested in taking part, I'll start it sometime in October next year. So the goal will just be focusing on 4 different conditions. One would be the scoping review to actually identify how diverse are the participants, but also how diverse are the researchers in these 4 different conditions: Alzheimer's disease, stroke, depression, and PTSD, because they're the ones affecting minorities a lot, but also they're the ones who are actually who have profound disparities. But also, aside from understanding the diversity in participants and researchers, we'll also aim to look at whether they are engaged. I think if Brett Schultz, is also like an advisory board member in this, whether or not they're actually, there's opportunity for co-creation, for results sharing, or it's just them going in and out and that's it. And so then we will contact them, and then there will be like surveys and interviews with researchers to understand, to what extent are the challenges for scientists to actually have diverse participants in these conditions. And we will not limit the type of study, so it could be from a genetic study to a psychological study to a service delivery study, as long as they involve these conditions and they're in Australia. And so these survey and interviews would help understand, what are the challenges really for researchers to have diverse participants. And then at the end of it, we'll have a workshop with not just researchers, but also with bioethicists, with Australian medical and mental health organizations, with journal editors, with human research ethics committee members, to understand guidelines, and of course people with lived experience or people who represent them, to understand, how do we conceptualize racial or ethnic or ancestral diversity in Australian brain and mental health research, and how do we move forward? Because this is, I use a bioethics FOR code, so I have to use or to explain how it will improve concepts like, anti-racist neuroethics and scientific epistemic injustice. That's it. Thank you so much for giving me a chance to present.
Thanks, John. That was so cool, so interesting. I was thinking as you were talking, when we teach students about ethics in research, we often take them back to not that long ago when minority populations were abused by science, to test around, various kind of infectious diseases. And I was just wondering how you think that, fairly recent history of actual racial abuse in science has kind of morphed into this new area of thinking about, actually we need racial diversity in science.
I think this one is actually really more pronounced in the US, especially, like in Baltimore, where, it's not just these remote communities that have been abused, but, even with people going to Johns Hopkins actually have been, I guess, taken advantage of, or, with the HeLa cells. But I think that's why context might be important, because not all countries kind of have that. I mean, there's of course colonization and slavery, but some of them have different historical baggages, but also different histories of multiculturalism and migration. So I think, this is why there's need to reconceptualize research ethics, because, well, of course, trust could be an issue, but then the other thing is that sometimes we become too paternalistic, like, we don't want any abuse to happen, so we don't, it's like having minority groups entails a lot more work for researchers. So I think it's trying to really resolve that dilemma of, because of all of these, then now we don't really know much how particular interventions are effective, but not just effective, but if they even have uptake, especially for digital health, especially for, alcohol and drug services, for instance. It's like, well, do people on temporary visas actually visit the AOD services? Because, well, I mean, if they get caught by the police actually taking a bus because they want to test it, then it would have a different repercussion as someone who might be a citizen.
We have a question online. Susan, would you like to unmute yourself, or?
Yeah, thank you. Yeah, I think you were navigating into quite a new territory where we actually have to look at statistical kind of aspects and medical aspects. And when, as a medical person, you meet a patient, of course, they are all different. That's quite clear. Maybe as a conclusion, taking pretty far, I guess, from your talk, would you consider that actually the researchers looking at themselves a lot more, and maybe it would go into a relativist kind of attitude, but I think it's all very Anglo-centric, and isn't it important to see the limitation of the researchers primarily, and patients or clients secondarily?
Yeah, thanks, Susan, and yeah, it's nice seeing you again. And thanks for coming to my talk. I've chatted with Susan last year. So yeah, I think it's like it sometimes becomes very complicated, because I mean, sometimes it's like, as we've seen from the COVID study, minority researchers don't necessarily lead to increased minority recruitment because it depends on where they are. But I think it's like, well, something is better than nothing. At least for instance, if you have epidemiologists and someone coming from a minority background or from a migrant background. And it's like there are things that you have experienced that might some people might not necessarily think, like these electoral roles, which something is a very common practice in Australia, I guess, for recruiting participants. But then, well, it's quite obvious that well, of course, if you cannot vote, then that means you're a resident or a student. Then you're automatically excluded from these research because, well, you're not in the list of where to send. So I think it's really important for researchers to be reflexive of the role and of the power relations. But I think it's important to also have allies, because of course it's not just, we just don't need to put all minority researchers, but at the same time, have people more aware of these limitations in research. And that's why I guess hopefully through this decade we could collect more data. I think the last study that did this was 2010, who actually collected that. I think it was just for anxiety actually, so yeah.
Great. We might have a question on. Oh, okay. Any other questions online or on the room? We are at time though, but yeah, maybe one more from Nicole.
Maybe a quick one. I don't know how quick it will be. I was just curious, you had a really interesting slide where the researcher was talking about how including all these different races and ethnicities and stuff can kind of snowball the effects, and the statistical analysis will become different, and you have to, increase your sample size, and that becomes really challenging, and you've already highlighted a lot of those issues as well. So do you have any specific practical solutions that you think we can do whilst we try to build this space? And is it targeting specific populations? Is it creating research designs where we're comparing some, a lot of it is white males who've been studied already with different race and sex or gender or things like that? Or, I mean, I come from a quantitative space, so.
Yeah, I think it's like the other dimension, which is a bit more complicated because, it's like, even with among the omics, actually, it would have a very different kinds of analysis. Where, a lot of, so I guess, sometimes you have this N of 1 trials where you could actually determine from just, having one person.
Yeah.
Which of course, when you have a diversity, you don't need to have this kind of, great number. But I think one of the other issues would be, when we collate data, but then you have to have individual level data for that, right?
Yeah,
Because
sorry.
it's like, well, first, of course, it's sort of reporting, how would we know what we don't have if we actually don't have these reports, but then it also comes with other questions like, well, which classification would you use? And if you have publications from different countries using different census categories, is that even a valid classification? Like in the US, all Asians are lumped together, which of course is kind of like, if you look at biology, it's quite different, and in some ways culturally as well, if you're looking at behaviors, for instance. So I think there's no easy answer, and that's why I think hopefully it's actually more of a question now, because how do we unpack these issues across different conditions, across different types of research? Because in some cases, it's like, it's not even the race or ethnicity, it's what language you speak, right? So I think,
Fascinating.
but yeah, the question.
There's a lot of work to come.
Yeah, I think there's so.
It's a very exciting space, though.
Yeah, thank you.
Congratulations.
All right, well, I think that's a good place to leave it. Thanks again, John.
Thank you so much.
Yeah, and just once again, just a reminder that we won't have any seminars for over the teaching break. So we'll see everyone on the 21st of September. All right, thank you.